Yeah, so thanks, Henry. So I'm actually really excited to give this presentation. I've been hoarding cases, I think, for close to 2 years to just try to put something together from a theme standpoint. And it's a topic, lung ultrasound for pneumonia. It's a topic that there's definitely some controversy, and there's many questions that we still have left to answer. This talk is going to be a little bit different. This is not meant to sort of show you sort of undifferentiated findings and what else is going on. The spoiler for the goals and objectives here is the spoiler is that everything is going to be a pneumonia case. So the answer is going to be pneumonia every single time. But we're gonna and I appreciate that Sig is here because sort of Sig is one of our, I think, de facto experts in lung ultrasound for pneumonia. We've probably, many of us have read some of the work that he's put together. And so I'd love to hear what he thinks about some of the potential controversies that I may bring up during this talk. So how are we going to do this? We are going to review 8, and I like to call them 8 spectacular cases. And it was pick 8 out of a bunch more that were probably eligible. And we're going to review some current evidence, but just with time constraints, I'm not going to be able to do deep dives into some of the research paper that I'm going to present, but just sort of highlight some key points that are applicable to the case as presented. And hopefully we'll have some time to discuss and maybe generate some ideas for research. But first, we're going to take a ride on the DeLorean.
Nice,
And
Antonio. Nice.
Very nice, Antonio.
we're going to start November 10th, 2022. So about a year ago, Rahul presented some vignettes, gave us chief complaints, some vital signs, some exam findings, some labs, and some ultrasound images that we all got a chance to look at. And then he asked us, would you treat this with antibiotics? Yes or no? And in this particular case, the breakdown was 50-50. It was a 4-year-old. And then in this other case, the same day, a 5-week-old that was RSV positive, same thing, vitals, exam, lab, some ultrasound findings. Not as many would prescribe antibiotics, but still 1 in 3. So we were a little bit all over the place. And then we're going to take a ride forward in time to May of this year, where Erica presented a case where she had a 4-centimeter consolidation with shred sign in a 3-year-old that had an asthma exacerbation and fever and was admitted to the PICU. And this patient did not get antibiotics, continued after the first dose in the emergency department. And I think it caused great consternation and possibly some lack of sleep for Dr. Constantine. She followed up with the family, and the child ended up doing fine off antibiotics, which reminds me of a case I had back in 2020. And so this was a 2-year-old, kind of similar, fever, respiratory distress. This was when I would say, starting to dabble in lung ultrasound. I've not been doing lung ultrasound for that long, where I've sort of integrated it into my clinical practice, like I do today. So when I saw this, I said, well, this is more than one centimeter. It's got the shred sign. It's got some bright stuff on the inside. This is different. This is focal. Actually, there was a right upper lobe infiltrator atelectasis on the x-ray. So this was real. And I actually sent a text message to some colleagues of mine at the time, and I said, what do I do with this? Should we treat it with antibiotics, yes or no? The most folks that wrote back while I was on shift said that they thought that it was reasonable. We did ampicillin, and then the PICU stopped antibiotics, treated the patient as an asthma exacerbation, required BiPAP, the whole thing, and she recovered. So this is not helping. It's not helping me as the lone wolf, as I sort of feel sometimes when it comes to lung point of care ultrasound in the pediatric ED. Well, I may not be just a lone wolf, but we have a small wolf pack, but I could count on one hand how many physicians or clinicians in our hospital actually do lung point of care ultrasound and integrate it in their practice on a daily basis. So I am proposing shifting the goalposts to some degree when it comes to pneumonia by ultrasound. There are a bevy of findings that are so nonspecific and so early that we just really don't know what to do with. And we haven't had a chance to study these thoroughly. So this is this part of the goalpost here, as opposed to a constellation of findings that I think are a little bit more firm and definitive for something that we could rule in as a pneumonia. And so what are those findings? So pleural effusion associated with hepatization and associated with fluid-filled bronchograms, which is what makes the appearance of hepatization of the lung tissue, or part of the appearance of hepatization of the lung tissue, and dynamic air bronchograms. So I would say right now, these are the big three for us in terms of more advanced pathology to hone in on a pneumonia diagnosis. And so for the purposes of this presentation, every case that I'm going to present to you is going to have 1, 2, or 3 of these findings. And we're going to jump into the spectacular 8 with case number 1. Every case has a title. The title of this kid is Tough Kids in Tough Spots, because this is a case of an awful pneumonia in a pediatric patient and a 6-year-old patient. So this child was not signed out to me. This child was referred to our ER from an inpatient unit during a very busy respiratory season at a time when we did not have any PICU beds available for 24 hours. Healthy 6-year-old had been diagnosed with pneumonia, had been on ceftriaxone for 5 days, decompensated from a respiratory standpoint, vancomycin was added, and did have a past medical history of asthma. Arrived and didn't look awful, like some work of breathing, some tachypnea, but wasn't grunting, didn't have accessory muscle use, and was only on 1 liter of oxygen. And no breath sounds on the right, but only 1 liter of oxygen, high white count, bands, procalcitonin was elevated. This was the x-ray. Oh boy, not great. And so I had the opportunity to perform a lung ultrasound on this child, which I did. And we start on the right side in longitudinal axis. And you can clearly see here a small pleural effusion. We can see here some tissue that shouldn't be there. But what I like to show about this case is what I had stopped there wouldn't have gotten a complete picture. So if you bring the probe to the back posterior and turn it into a transverse orientation, you can clearly see pleural effusion with some bright debris inside of it. The lung is getting smushed down over here, maybe some suggestion of dynamic air bronchograms here. And with this image alone, you'd think this is going to require some high level of care, chest tube placement for sure. And this was one where there was no PICU beds available. So what do? I don't know. I wish I didn't get the ultrasound, because now I have this in my mind and I'm very worried about this young child. But I can't keep him in the ER for 24 hours. So we roll the dice, we admit him to the floor. Ultrasound's done by the radiologist. It shows the same findings. Surgery is consulted. They defer to interventional radiology, gets a chest tube through interventional radiology, and he does fine. Never went to the PICU. He was hospitalized for a little bit over a week, treated with antibiotics. All cultures were negative, and completed a course with augmentin. And I was just amazed on this case with that ultrasound that this is a child that never required positive pressure. Like just the left side, the oxygenation from the left lung seemed to suffice, and never required BiPAP or high flow or anything like that, with essentially a awful pneumonia on the right side. So I like to start with this case just because kids are so challenging. And before I get to 2, 3, 4, 5, 6, 7, 8, we're going to take a slight detour and just talk about a little bit of the existing literature related to pneumonia. And we're going to touch upon things related to x-ray use, things related to our physical exam, and things related to lung point of care ultrasound. So Those of you that work with me know that I like to bring this paper up all the time. This was published in 2017, evaluation of 23 prospective studies, almost 14,000 patients, looking at test characteristics of the physical exam and other clinical findings like hypoxia and tachypnea, using an infiltrate on chest x-ray as a reference standard for pneumonia. And what did the authors conclude? Well, the authors concluded that the stethoscope isn't very helpful. Crackles, wheezing, diminished breath sounds are not associated with a radiographic pneumonia diagnosis. So what do we do with this? Well, this was one of the many patients I could have selected. This was a 20-month-old, healthy, vaccinated, presented for the fourth time in 4 days to our emergency department with persistent fever, cough, increased work of breathing, and had been diagnosed with bronchiolitis every single time. And I happened to be working with a medical student and a resident that was interested in ultrasound. And I said, oh, let's just look for B lines on this patient. And surprise, surprise, there's a pleural effusion here. And there is some lung consolidation changes going on here. So this is not just bronchiolitis. And you can see it on the x-ray as well. And so you get a sense of how hard it is sometimes with these patients that are tachypnic and have some shifting physical exam findings, how tough it is sometimes to discriminate pneumonia from other causes of lower airway inflammation and disease. And so I've read this manifesto. It mostly covers adult pathology and not specific to pediatrics, but it's a nice review on the origins of the physical exam, the advent of the stethoscope in 1816, and it's a crash course on POCUS as a disruptive force in medicine. And the book does a nice job providing historical context and insights into POCUS integration with the physical exam, and uses some research to sort of prove the points that it's trying to prove. And for pneumonia specifically, the physical exam with auscultation has the following test characteristics. This is an adult patient, but can you imagine if we ordered every respiratory patient, we ordered the same test with this level of sensitivity and this level of specificity, we would be laughed at. But yet we always talk about the importance of the physical exam and the clinical evaluation when it comes to pneumonia. Chest radiographs, also poor sensitivity. We talk about how findings on infiltrate will often lag the physical exam, which is true. So sensitivity is quite poor. And when it comes to point-of-care ultrasound, I wouldn't say just point-of-care ultrasound. When it comes to lung ultrasound, our test characteristics do improve. This is probably better in pediatrics. And without a question, ultrasound is better than x-ray and physical exam for effusion diagnosis. So as part of this detour, I try to look at, well, how good is consolidation on x-ray to predict pneumococcal pneumonia? So this was a multi-center retrospective paper published in Pediatrics in 1998, part of a pneumococcal surveillance study. Again, the idea here is that x-ray findings can lag the clinical exam, so sensitivity isn't all that great. But if you look at these patients, all these patients were diagnosed with pneumococcal pneumonia, either from some sort of PCR testing and they had respiratory symptoms or clinical exam findings that were suggestive of pneumonia. And they looked at inpatients and they looked at outpatients. And even in the inpatient group, the sicker group, on the x-rays, when they were obtained, only half the time was there a consolidation. And I was actually quite surprised when I read this, because this makes our reference standard test that we use in a lot of the research that we do for pneumonia pretty suspect. And then the one study done in 2015 that was a meta-analysis of the 8 highest quality studies available, most of them not performed in the United States, did show that ultrasound, when compared to x-ray, has fairly good test characteristics. The The one caveat here is that in the majority of these papers, the operators, those that were holding the ultrasound probe, were highly skilled, described as highly skilled operators. And I'm going to end the detour for now so I can get into case number 2, which I like to title "Be Like Galileo." This is my Galileo case. So Galileo, as many of you know, was an astronomer and scientist in the 1600s, and he was a healthy skeptic. So back then, the general consensus by theologians and the scientific community was that the Earth was the center of the universe, and then that the sun revolves around the Earth. This was essentially a literal interpretation from Scripture at the time. But Galileo used the power of observation to prove that that was not the case. He claimed that instead the Earth actually revolved around the sun. And so I am going to present a case where I had my Galileo moment, where I could actually see something with ultrasound that could not be inferred or seen by the traditional physical exam or chest radiography. The one caveat with being like Galileo is that Galileo ended up, famously convicted of heresy for his absurd and foolish philosophy at the time. So he's a hero, but sometimes being a healthy skeptic gets you into trouble. So here we go. This is a 6-year-old female, multiple admissions for cough, hypoxia, and respiratory distress. You can see here all the visits. They span the course of about a couple of weeks. She had been sick for a couple of months, URIs, one prior COVID, one prior Coxsackie virus, all sort of regular stuff. And she was brought in on the initial day for shortness of breath. She had no prior history of asthma, shortness of breath, and no focal findings on lung exam as was documented. And an x-ray was done, probably because she was having difficulty breathing and no good explanation. And then the PA doesn't look that exciting, but on the lateral, you can see that there is an area there suspicious for pneumonia. So she was diagnosed with pneumonia by x-ray. She was admitted 24 hours. She was starting on cefuroxime because she had a penicillin allergy. She had an amoxicillin allergy. And she was on 2 or 3 liters of oxygen, weaned off over the course of 24 hours. The rhinovirus came back positive, and didn't get an IV and didn't get any lab works done. She returned 2 days later with increased work of breathing and once again an oxygen requirement. Started on 2 liters, readmitted, cefuroxime was continued, no PIV, no labs were done. Curiously, a rhinovirus was repeated that was negative on this admission. She did get an x-ray, and it looked a little bit worse. So it looked a little bit worse, a little bit of right middle lobe, something going on here. And on the lateral, you could see a sort of accentuation of the spine sign there as well. Right there. Sent home, had a short interval improvement and returns 9 days later after having finished the cefuroxime. And this time she was wheezing. She was wheezing for the first time. Nobody had noted wheezing before. She was given some NEB treatments. Her oxygen bumped up a little bit from 94% to 99%, given dexamethasone. And she was sent home in the middle of the night from the ER after this x-ray was done, which looked much better on the right side and not too bad on the left side, a little bit of haziness here in the left lower area. So the assessment was that things were trending in the right direction based on the x-ray. And she was just developed bronchospasm and a new reactive airway disease picture. But she returns less than 10 hours later to me in the morning, and I say, "Hi, I'm Dr. Antonio. I love to do ultrasound. We're going to do ultrasound and see what's going on because I'm confused, and I don't want to do a 4th x-ray." Also, the dad, I remember this dad was so nervous. He was like palpably shaking in the room just because his daughter that was otherwise healthy has this pneumonia that just won't get better. So we do an ultrasound, and this was the Galileo moment, which I was shocked to see based on that x-ray on the left posterior lung. So even here with the linear probe, we can see the fluid-filled bronchograms right there. And it was so large on the linear probe, I had to change, the lesion was so large, we had to change to the curvilinear just to get a sense of how expansile it was, and you can even see a fissure here, and it's a pretty impressive pneumonia. And so I was confused. We readmitted. We gave a dose of ceftriaxone. I'm not sure if that was necessary now in retrospect. She'd never had a fever this whole time, but she's got this crazy pneumonia. I think it's a pneumonia. Pretty sure, just based on what we know by lung ultrasound. But I was debating other possibilities like some funky sequestration or something else. So during this hospitalization, number 3, we get a pulmonary consult. She's managed as a reactive airway cough variant, cough predominant asthma patient. She started on azithromycin for its anti-inflammatory effects and Flovent. And then the next morning, we go up to the floor, we rescan her, and there's no change. And we did this with the pulmonary team. The pulmonary fellow actually obtained these images while we were there together. And you can see a very tiny pleural effusion here in front of this consolidation, which again, I was very surprised to see just given that x-ray. And here we have spleen, diaphragm there, and that pneumonia sitting on top of the spleen there on the left side. And she was in the hospital for 48 hours on that treatment, Flovent, azithromycin. She was watched for a full 24 hours off oxygen, which was reasonable given this is her 3rd admission. And I saw her in clinic 3 weeks later, to never get to do. And she had a normal ultrasound. She has A-line pattern, that's spleen. She had A-line pattern, diaphragms here. And she finally recovered. And she had normal spirometry testing, no obstructive pattern, even though they continued her on Flovent. And so I believe, she was never tested, but I believe this was likely a case of mycoplasma. And mycoplasma with lung ultrasound features that I would not have thought would be present. And only because she just seemed to respond to the azithro and the Flovent, and the asthma testing didn't bear an obstructive pattern in pulmonary clinic. So it must have been the azithro. The other option is just a viral pneumonia that eventually got better, but I don't know. I feel like a viral pneumonia in 2 weeks probably would have improved, or we would have had something else. So I looked at this question: what are the lung ultrasound features could you see with mycoplasma pneumonia? And there's actually a study out of China looking at common mycoplasma pneumonia versus refractory mycoplasma pneumonia. And so refractory was defined as mycoplasma pneumonia that had persistent findings on imaging or worsening findings on imaging after a course of azithromycin or erythromycin. And the mycoplasma was diagnosed by either IgM or by PCR testing. And so the very interesting thing is that even for common mycoplasma pneumonia, they saw pleural effusion in about 30% of cases. And although the consolidations were larger in the refractory mycoplasma cases, there were consolidations in the common mycoplasma pneumonia cases as well. And so after I read this article, I sort of reaffirmed my hypothesis that this patient probably just needed azithromycin to improve. Case number 3 is to be admitted or not to be admitted. This was a 5-year-old signed out to me at 7 o'clock in the morning after a very tough overnight shift, very busy, high acuity, lots of admitted patients. And she was transferred to our hospital for altered mental status and lethargy as a chief complaint. And again, we were sort of tight on beds during this day. And you can see, I love these chief complaint snippets that we get because it tells you a lot and sort of synthesizes sometimes a lot of the key things that the parents tell the nurses at triage. So what is the family worried about? A lot of times comes through in these little chief complaint snippets. And so this 5-year-old had a lot of nonspecific symptoms: headache, cough, poor PO, lethargy, dehydration, vomiting. And at the other hospital, they were so worried about her. She got IV fluids, antibiotics, chest x-ray, and a head CT. So she must have looked terrible. And when she was transferred to us, she had respiratory effort that was normal and breath sounds that were normal. And I love it when my team does, for these funky cases, sort of just a bit of a modified rush or just some images for shock. and they looked at the heart, which looked fine. There was no findings here. She still had a collapsible vena cava after IV fluids. And it was curious, during sign out in the morning, they mentioned that she had gotten an x-ray, and the x-ray report was officially read as negative, but there was some comment in passing that maybe there was something on the left side. But if you look at the medical record in the chart, the x-ray was read as negative. And so I had something to at least try to scan the left side of her lungs. And this is the probe starting from the base here. So the probe starts at the base here. You can see spleen and coming all the way up to the axilla, spleen, pleura, another spleen, pleura, no, a consolidation up here in the left axilla. And so if we hold the probe there, we can see it's a pretty good size shred pattern. And you can even see dynamic air bronchograms. So we finally had an answer. We had a diagnosis, and she, after her IV fluids and some antibiotics, she wasn't looking as bad as she had been at the other hospital. So I had a conversation with the parents. I said, hospital's full. Your daughter's not on oxygen. She seems to be drinking a little bit better this morning. Why don't we send you home on an antibiotic course for pneumonia, since we now know what's going on? And I typically don't love to do 2 antibiotics in general, but this case where it was such a profound sort of presentation, and I'm kind of messing with the plan to admit versus to send home, I did err on the side of just covering all my bases. Plus I had that other case that I just presented in the back of my mind. And so we only did 5 days of both. We did 5 days of acitro, 5 days of amoxicillin. I had to call, and I had to call just to follow up because of that disposition decision was sort of a bit of a big deal. And she was better. She responded and she didn't come back. So I thought this was a huge win, because without POCUS, she would have been admitted. Case number 4, pretty good timing. So I'm in bed. I'm about to go for a shift. I get these AAP emails in my in basket, and I literally get the do not obtain radiographs in children with bronchiolitis, croup, asthma, or first-time wheezing as like the suggested clinical practice guideline. I said to myself, oh, this is fantastic, because it doesn't say anything about lung POCUS. And so this was hot off the press. And literally that same day, that same afternoon, at the end of my shift, I got a 5-year-old with asthma, fever, wheezing, who presented with an asthma exacerbation. And so I don't do lung ultrasound on every child with an asthma exacerbation. That would be impossible to do. But there was something I didn't like about this young boy in particular. He just seemed a little bit sicker. He was tachycardic, and he just seemed listless. And so yeah, I had the time in this particular moment to do a lung ultrasound, and look what I found. I found something pretty substantial, fluid-filled bronchogram right there, and this was right abutting the heart, in the right anterior lung zone. A little bit of shred sign, some air bronchograms. And so we get an x-ray to follow this up, and it's a typo here, but it was read as pneumonia. And so I signed out as obligatory chest x-ray, which I don't always do, but in this case, I did end up getting the imaging study. Also because I had to sign out, and I think that the confidence in interpretation of lung ultrasound is a little bit different across my colleagues. So got the x-ray was positive. And I thought he actually probably was going to be admitted, but he got some IV fluids and was sent on ceftonir, and he did fine. And so what happened after he was discharged was that the flu test came back positive. So one, I think we caught pneumonia early, especially with the clinical practice guidelines saying that we shouldn't be doing x-rays. But what I don't know is how many of that child would they have done fine without the ceftonir course? And I don't know how we answer this question, to be honest. the systematic review and meta-analysis of influenza pneumonia patients and bacterial superinfection, the range for co-infections is about 2 to 65%, with the majority being strep pneumonia and staphylococcus as well. And this is 27 studies and 3,000 patients. But what I don't know is which one of these patients are viral pneumonia, influenza pneumonia alone, which we'll see something on ultrasound, and how many of those that we see something on ultrasound actually have strep or some other bacterial infection. And we really are going to have a tough time studying this without multi-million, maybe not multi-million, but $1 million grant to do PCR testing and just like prospective longitudinal assessment of our patients. All right, the cases get a little quicker as the presentation winds down. So 5 and 6, do you see what I see? These cases are comparison of what is seen on X-ray versus what is seen on ultrasound. And the first case is a 6-year-old that has pneumonia, has a pneumonia on X-ray, had been diagnosed clinically as an outpatient, was already on ceftonir for 5 days, is ill appearing, is tachycardic, is tachypnic. He has pneumonia. And he has his X-ray. And this X-ray is whited out, and it is tough to know, or for me certainly, tough to on a AP, tough to know how much of this is fluid versus how much of this is consolidation. So linear probe, probably not good enough here. I mean, you're just not seeing everything that you need to see, but to be able to see down here at the diaphragm over here and the base of the lungs, setting a depth of 12 centimeters really narrows the field of view. So this is a case that's perfect for curvilinear. And you can see a pretty complex sort of loculated fluid collection here, pneumonia going on over here. And so something like this probably deserves cross-sectional imaging. This is the transverse view again, which I love, posterior, big effusion, maybe some lung tissue here, that's okay. And then other findings suggestive of pneumonia over here. So he did get a CAT scan. I think the ultrasound did sort of confirm more effusion, less consolidation. And there were some complex features on the CAT scan. So we have necrotizing findings, air pockets here. But what's really neat is that if you flip the CAT scan 90 degrees, all of this wedge over here, you can see really clearly on the ultrasound that we obtained. So he progressed with a complicated hospital course, was diagnosed with multifocal pneumonia, cavitary necrosis, empyema, required a chest tube placement through IR. Again, all cultures were negative, was in the hospital for a couple of weeks, and was treated with antibiotics. But I do feel that the lung ultrasound was helpful in making a good informed decision about doing a CT scan in this case.
Antonio, can I chime in?
Please. Where do you want me to stop?
On this case, the empyema and ultrasound. One is not all empyemas reach the pleural line, so you can miss them. But of those that do, and I don't remember the reference, but it's in the review article I wrote. But there is a study, very nice study referenced in that article that looked at CT versus lung ultrasound for empyema. And when you see these characteristic signs, particularly stranding, it's been shown to be essentially equivalent to CT scan, and they ended up recommending for these kind of findings, no need for a CT scan.
Mm-hmm.
Not that we would not do that, but I think the literature that's out there suggests that you could probably depend on your lung ultrasound, which was actually nice.
Mm-hmm. Thank you. Yeah, if I was working with you, Sig, and we could carry on the care in the hospital like tomorrow, I feel like we get
Well,
doing a
I think
CT
I think most people would do a CT scan, but just so you know,
one
the
day.
literature is very supportive of ultrasound.
One day. And so it's actually a pretty good segue to this next case. So here we have a 7-year-old with asthma and respiratory distress. Pretty bad vital signs, tachycardic, tachypneic, 90 O2 90%. And I put the weight, the growth chart weight here, just to sort of highlight that maybe we shy away from these patients from an ultrasound standpoint because we feel like we're not going to get images that are easy to interpret. And lots of findings on exam, retractions, wheezing, decreased air movement, seem to be focal wheezing on the right side. So we're in the abdomen setting here, and I'm mostly looking for probably a pleural effusion. And we have liver, and we have not a great view, to be quite honest, but we have something maybe here. Here on, this is abdomen setting, and then this is lung setting. So now we've moved a little bit the probe, and you can see more consolidation here with some static or bronchograms, most likely here, and some good B lines, skipping different pleural spaces here, right posterior on the lung setting, right axillary on the abdomen setting. But what I don't see clearly is any evidence of pleural effusion. I see most consolidation. So after this ultrasound, we get an X-ray. X-ray looks terrible. Again, she's a patient with a high BMI, and it was read as a large right pleural effusion without atelectasis. And this was my reaction. And I went back to the manifesto, and we have a way to text message the admitting residents. It's like encrypted and secure, so you can add some information about the patients. And essentially the message was, please do not do anything other than have radiology, do an ultrasound, and do not do a CAT scan on this patient. It's pneumonia, they're much more than effusion. And I think in this case, our POCUS helped us with a better use of resources and helped us avoid an unnecessary CAT scan. And no CT scan was done, no surgery console was required. And to the floor team's credit, they did have radiology do an ultrasound, which confirmed that it was consolidation without effusion, which was great. This was impressive.
Yeah, Antonio, if you look at the X-ray, the mediastinum is shifted to the right.
Yeah, and but that's something that Lei Chen you can do. But the inpatient service of our house staff on the hospital service, I think less likely able to make an assessment like that. In terms of, I think what Leigh's trying to say, if you have an effusion that's so big, this should be shifting the other way. The heart, the midline should be shifting the other way. But what I think we mostly do in our clinical practice is read the impression of what our radiology colleagues are evaluating. All right, the second to last case is down the rabbit hole we don't go. I don't like to go down the rabbit hole. And this is a slightly different case than some of the ones that I've already presented. This is a 6-year-old signed out for an overnight shift to get waiting for the appendix ultrasound. She had belly pain, fever, vomiting, diarrhea. And on physical exam, there were no focal lung findings. And on her abdominal exam, she had generalized tenderness without peritoneal findings. Fever was high, 103, 104, 4 days of fever. Vomiting had been getting better, no constipation. And the belly pain did wake her up from sleep, and was the reason that they brought her into the emergency department. So she's at ultrasound. She's getting her ultrasound. It's kind of busy. The ultrasound doesn't visualize the appendix. The white blood cell count's 25,000. So what do you do? This is a question I asked our fellows when I presented some of these cases to our fellows. What should we be doing? So we see the patient, reassess, don't order the CAT scan right away. Evaluate the patient and meet the patient, and they tell you that during the ultrasound, the pain actually shifted from the lower abdomen to the flank on the left side. and you hear her cough, and the cough has a sort of productive quality to it. And this is sort of like a new nugget of information that was not handed off to you. So I said, well, at the very least, we should be thinking about pyelonephritis and hydro and stuff like that. And we can look at the lung bases at the same time. And lo and behold, on ultrasound, we can see a big consolidation here above the diaphragm, spleens over here, sagittal view. And once again, just turning the probe 90 degrees in transverse, you can clearly see the consolidation with the dynamic or bronchograms here. And so we get an X-ray, and she's diagnosed with pneumonia, and she's admitted because she was dehydrated and tachycardic, and got a course for CAP and did well. And we did not go down the rabbit hole, and ultrasound saved her a CAT scan, which would have picked up the pneumonia, but the CAT scan would have been likely protocoled for rule out appendicitis. And then the final case is for posterity. And, you know, I really feel strongly we have to find a way to teach lung ultrasound well to more folks than the wolf pack. Want to make a bigger wolf pack. And so this was a very recent case that I had. Also a rule out appy kind of sort of case, a 5-year-old, fever for a day, abdominal pain and vomiting, and decreased urine output. And then there was a big language barrier. We couldn't get a Romanian interpreter on the audio system, the Marty card system that we typically use. And I'm trying to Google Translate with mom to sort of try to piecemeal a history together. And by the time I saw the patient, had already had an ultrasound, which was borderline, sort of equivocal, something at the tip, measuring 6 millimeters without hyperemia. The CRP was up, the white count was up. And the big issue here, well, there's multiple issues, but one of the issues here was that the child was in pain. And so I in my recollection of appendicitis cases that we've had where the patients have had a difficult time urinating, oftentimes those patients are perfed, there's free fluid in the pelvis, there's something funky going on. So we go in there to start just to get a general sense of the bladder volume, anything behind the bladder. And this kid only has 40 cc's of urine in the bladder. So this kid is not having urine retention. This kid is dehydrated and probably needs IV fluids, and that's why he's not voiding, even though it's been 8 hours of not voiding. And I said to myself, well, I'm here anyways. I might as well take a look at the basis. And this is what I saw. I asked mom, I go to the Google Translate on the phone. I asked mom, had he been coughing? And she says yes. And this, I believe, is both. So this is left. So this is both images of the left side. You can see a small little pleural effusion and a little wedge of lung tissue here. And so the right side had some similar findings as well, right above the diaphragm, little small wedge of fluid-filled bronchogram there, B-line's right above it. And so I was inspired for the first time, to put some color Doppler on. I think I was inspired by Magali Gauthi, who sort of presented on this. And I like the concept of hyperemia and inflammatory findings for something smallish in the lungs to differentiate atelectasis from consolidation, because we shouldn't have positive hyperemia or inflammatory changes in areas of atelectatic lung tissue. So we did this at both bases, on the right side, left side. You can see these changes here, even with the patient breathing. And I didn't do a CAT scan, and I treated this child for atypical pneumonia, just based on the age and the bilateral findings. And he did fine. Did not call the surgeons, did not do a CAT scan. And this one I couldn't call because of the language barrier, but I've looked at the medical record multiple times, and no visits to our hospital or our referring hospitals where he came from to us. So I propose a potential shift in the paradigm, or in at least the goalposts, for what we would potentially consider as pneumonia And I think one of the areas where we could do some more investigative work is color Doppler. This was another pneumonia patient I had, a 5-year-old with 5 days of fever, cough, abdominal pain, and also a normal lung exam that we diagnosed with pneumonia. And that seemed, I feel like I haven't had to play with the sensitivity scale. If I'm in lung setting, when I hit the color Doppler button, whatever that scale is set at, I haven't had to adjust it. And then I just have another one. This one was, I think, trickier because this kid was younger, the lesion was smaller, and it was a toddler with some sort of tachypneion exam. So it was harder to sort of get a sense, is that artifact from breathing? And I try to make the box really small, as opposed to here, I think I'm seeing more sort of inflammatory hyperemic changes within the box. Whereas here, the blue, I think, is artifact, and maybe that red is more real. The red blue is more real. This young girl, she ended up being admitted for O2 requirement, and the floor team checked the procalcitonin that was elevated, and they completed the course for pneumonia. And then for good measure, and this is my last case, and this is only because it was my Tuesday overnight this week, I had a 19-year-old with metastatic Ewing sarcoma, this kind of sad presentation, with fever, chest pain, shortness of breath, and symptoms that were more exertional, who was in shock, and tachycardic, and tachypneic, and setting 84% on Romer. So I thought he was a pretty high risk patient for a pulmonary embolus. And so I started doing cardiac evaluation, and I had a very tough time getting a good apical 4. And as I tried to do the subxiphoid view, I saw this, and I said, well, I'm clearly imaging the wrong organ here. And with the phased array probe on the cardiac setting, this was the large loculated effusion that on follow-up CAT scan was more consistent with relapse and progression of his metastatic disease. But he had fever, so we gave him antibiotics, and this just happened, so he's admitted to the hospital. So in summary, even though there's so much that we still don't know, I really believe lung ultrasound is awesome and probably our most reliable tool to pick up pneumonia. Pneumonia is messy. It's a messy subject. It's messy to study. It's just messy. And I don't know how to get to nirvana for capacity building, because I feel like all these cases are compelling for why lung POCUS is best for these evaluations. And then our reference standard is flawed. So we're not gonna compare ultrasound to CT scan. And so we may never know how good lung ultrasound is for pediatric pneumonia. And I actually am on the camp where an X-ray is fine. It's like a fine option. It's nice to have options in life. It's busy. Lung ultrasound takes time. The patients don't cooperate always. So it's not the end of the world to get an X-ray. Sometimes it's better and easier for everybody. And with that, I'm going to stick a fork in it and finish.